So I have no disclosures, and I just wanted to actually refer to the title of my presentation here. Thyroid, how much blame does it deserve? And I think the thyroid is one of our organs that really gets a bad rap. We like to blame everything we can on the thyroid, and sometimes we should, but sometimes we really shouldn't. And so hopefully what we'll be able to discuss today is those instances where it is the thyroid's fault and maybe instances where it's not. So what we're going to talk about today is, first I want to review the normal hypothalamic-pituitary-thyroid physiology. And then once we've talked about the normal, then we'll be able to identify situations where patients may benefit from evaluation of thyroid function, and then we can determine how that's going to be abnormal. We'll be able to describe clinical and biochemical features of common pediatric thyroid disorders, and then we'll talk about next steps, what to do after we identify that someone may or may not have thyroid dysfunction. So as all good things do, we start with our feedback loops. We have the hypothalamic-pituitary-thyroid hormone feedback loops. And just to review, because this is important as we'll talk about thyroid function testing moving forward, we start in the hypothalamus where thyrotropin releasing hormone or TSH is produced. This stimulates the pituitary gland to make thyroid stimulating hormone or TSH, and this goes and stimulates the thyroid to make thyroid hormone. The majority of thyroid hormone produced by the thyroid gland is T4, and this is then converted to T3 in the circulation by thyroid peroxidase and other enzymes. And this is why if someone has their thyroid gland removed, the vast majority of the time people do really well with just T4 supplementation because we still have those enzymes in the periphery that convert it into T3. So we've made our thyroid hormone. The thyroid hormone then goes back and has negative feedback on both the pituitary gland and the hypothalamus to decrease the production of TRH and TSH. And so we have this beautiful regulated cycle of thyroid hormone production, unless it isn't beautiful. Thyroid hormone does a lot of important things. And so it is really important to determine if somebody is making the appropriate amount of thyroid hormone. It works in the heart as far as having a permissive effect on catecholamines. It allows them to function at their highest capacity. It also increases the expression of beta receptors on the cardiac muscle itself to allow the heart to beat more effectively, to have a more efficient stroke volume when needed. Thyroid hormone stimulates the lungs in regards to stimulating the respiratory system, the center, and increasing perfusion to the lungs, allowing for maximal oxygenation of the blood. It has an effect on skeletal muscle by increasing that development of the fast twitch type 2 muscle fibers to really allow us to use our muscles at the maximum capacity. Thyroid hormone has a lot of different metabolic effects. It increases or maintains your normal basal metabolic rate, and it does this by increasing gene expression of the sodium-potassium ATPase. Thyroid hormone stimulates the metabolism of carbohydrates and the anabolism of proteins. It helps with our glucose utilization by increasing the reabsorption of glucose in the bloodstream. It also helps to increase gluconeogenesis, so glucose absorption, glucose production. It helps us to store extra glucose by glycogen synthesis, and it helps us to use our glucose most effectively through glucose oxidation. Thyroid hormone stimulates growth in children. It stimulates bone growth and allows both brain maturation through axonal growth and myelin sheath formation. Incredibly important, especially in the early years. We know that congenital hypothyroidism is one of the most common causes of abnormal newborn screen, and replacing thyroid hormone can really help to optimize intellectual development in babies. And then thyroid hormone also has an effect on ovulation, which can influence fertility. So really important stuff. So thyroid hormone is really important. So we should check it in everyone. No, we should not check it in everyone, but when should we check? What are some good reasons to check thyroid function? And I've put these two screenshots here because sometimes we check thyroid hormone just because a patient asks us to. And is that the right thing to do? Is that not the right thing to do? We want to be careful not to just be a vending machine for labs and medications and just do whatever the patients ask. But I think it's also important to ask why. Why do you want me to check your thyroid function? What sort of symptoms are you having? And if you determine that the patient does have some symptoms that might be suggestive of a thyroid problem, then absolutely check when the patient asks. So reasons that I would recommend checking thyroid function is if somebody's got symptoms of hypothyroidism, and we'll talk about what some of the common symptoms are. Or if someone's presenting with symptoms of hyperthyroidism, absolutely a good reason to check thyroid function testing. If you examine a patient and they have an enlarged thyroid gland, that could certainly be an indication that there's something going on with the thyroid and should be evaluated. And if you have other reasons to suspect thyroid dysfunction, let's say that this is a cardiac patient who has just begun amiodarone. We know that amiodarone has a lot of iodine and this can interfere with thyroid function. So getting baseline labs and monitoring moving forward. If there's anything else going on with the patient that would make it likely that there would be something different with their thyroid function test. So we've decided we're going to do it. We're jumping on the thyroid hormone bandwagon. What do we check? And it depends what we're looking for. I went to a lab database and I just searched for thyroid function and there were 159 different tests that I could order. And we could order all 159 tests, but that would not be a judicious use of the healthcare system. And so instead, it's really important to think about what sort of answers do I need to get? What are the things that I'm looking for? And curate the tests that we order to really get the best bang for our buck. So common tests that I think about in clinical practice are TSH, or the thyrotropin, made by the pituitary gland. This stimulates the production of thyroid hormone like we talked about earlier. And if somebody has primary hypothyroidism, the thyroid gland is where the problem lies. It is not making thyroid hormone, and so the pituitary gland reflexively increases the amount of TSH to try to stimulate that broken gland to make thyroid hormone. And it doesn't make thyroid hormone, and so the TSH continues to be elevated to try to get some thyroid hormone out of that gland. If instead the problem lies higher up in the brain, in the pituitary gland or in the hypothalamus, the TSH, it's a grab bag. It could be low, could be normal, but inappropriately normal, or it could be even a little bit high just because it's not being regulated. It's just being produced without any sort of feedback. So it's less helpful in a central cause of hypothyroidism. We also think about our thyroid hormones, T4 and T3, and I will check one or both of these depending on the clinical situation. We'll talk about some of those instances. In all forms of hypothyroidism, T4 and T3 are going to be low because the thyroid isn't making them, whether it's not making them because it can't, or whether it's not making them because it's not being stimulated to do so. The end result is low thyroid hormone. So hypothyroidism, what are some things that might make us suspect this and make us want to check? Fatigue. I'm tired all the time. I'm feeling cold. I'm constipated. Irregular periods. If on exam someone has a goiter, or you listen to their heartbeat and it's a lot lower than you would expect for their age in the clinical situation. If somebody presents with pubertal delay or clinical signs of precocious puberty like breast development or poor linear growth, these are reasons to check. And the reason I say clinical signs of precocious puberty is that there's something called pseudo-precocious puberty that's caused because there's an overlap in the receptor that senses TSH when it's very, very high as HCG or FSH or LH because they have that common end unit. And so if someone has a lot of TSH, that actually can stimulate some breast growth, even though it's not true central puberty. Weight gain is not typical in hypothyroidism. And there is an asterisk because we will talk about this in great detail in the slides coming up. This is something else that we see if somebody has acquired hypothyroidism that started during childhood and it's affecting their growth. We can see that early on in childhood, this person was growing pretty well and they were growing consistently along their own growth curve. But then we can see they began to fall off the growth chart. And when they were evaluated in the office, their height was significantly lower than their mid-parental height estimate. And this is a very common growth chart that we'll see in acquired hypothyroidism. And if we can catch this early before their growth has been significantly affected, treatment can help to maintain their appropriate growth patterns. Acquired hypothyroidism is pretty common. It happens in about 1 of every 500 school-aged children. And the most common cause in the US is autoimmune or Hashimoto thyroiditis, chronic lymphocytic thyroiditis, autoimmune hypothyroidism. And this is a picture of Dr. Hashimoto who first described this finding. In other parts of the world, there are other common causes, including iodine deficiency. If someone has had surgery or radioactive iodine treatment for hyperthyroidism and they have no thyroid gland or their thyroid gland isn't functioning, that can also result in hypothyroidism. And then other more rare causes like infiltrative diseases like Langerhans histiocytosis, hemochromatosis, both of these are infiltrative, or a consumptive condition like a liver hemangioma where the thyroid hormone is just being used up so quickly that you can't replace it as fast as it's being used up. These can all cause hypothyroidism. So labs that I think about if I'm concerned or worried or want to evaluate for hypothyroidism would be that TSH, looking at the pituitary, and either a total or a free T4. Because we live in the US and we know that autoimmune hypothyroidism is the most common cause of acquired hypothyroidism, I will check antibodies to both thyroperoxidase and thyroglobulin to evaluate for that autoimmune cause. So let's say that we're worried about hyperthyroidism instead of hypothyroidism. Things that a patient might talk to us about are fatigue. They're tired because their metabolism has been increased so much, they're just all worn out. Maybe they're having heat intolerance, they're having palpitations because they have that permissive effect of catecholamines and that increased beta blocker expression. Maybe they're having diarrhea because the GI system is speeding up. And again, they may have irregular menses. On physical exam, you may notice that they have a goiter. You may listen to their heart and find that their heartbeat is much faster than you would anticipate, and they may be just fidgety and moving around and restless on the exam table. You may notice pubertal delay. You may notice growth acceleration because thyroid has that effect on growth. It increases the bone growth and muscle growth. And the causes that we think about are Graves' disease, the most common cause. This is an autoimmune cause. And other slightly less common causes in pediatrics are toxic nodules, various genetic causes. Central hyperthyroidism is incredibly rare, but you could have a pituitary adenoma making TSH, which then stimulates thyroid hormone production. Any sort of a thyroiditis, whether it's inflammatory or infectious, and then exogenous thyroid hormone, which we'll talk about. Graves' disease, as I mentioned, is the autoimmune cause for hyperthyroidism. And this is caused by thyrotropin receptor antibodies, which stimulate the TSH receptor. Looking at this graphical representation, we see two different thyroid cells. One of them has a TSH receptor that's being stimulated by TSH, producing the appropriate amount of thyroid hormone, which has that feedback on the pituitary gland, which allows the regulation of the system. The second photograph or picture, we have the autoantibody that's binding to the receptor instead. It's stimulating thyroid hormone synthesis, but because it's not being stimulated by TSH, there's no negative feedback. And so the receptor continues to be stimulated and continues to make excess thyroid hormone. And that's the mechanism for that ongoing hyperthyroidism and Graves' disease. We diagnose this with biochemical testing, looking at TSH, free T4, and in this situation, I do get a total T3 because a lot of endogenous hyperthyroidism tends to be T3 predominant. So if we only check the T4, we're going to miss that elevation in T3. And then I will also check antibodies specifically for Graves' disease, the TRAB, the TSI, and the TBII. If we're not quite sure We can do some imaging in this situation, and often I will start with nuclear medicine imaging with a thyroid uptake and scan. This gives the patient a low dose of radioactive labeled iodine that lights up in the thyroid gland, and if the gland is very, very dark on the scan, this indicates increased uptake, increased radioactivity, and hyperthyroidism. If you don't have the capacity to do a nuclear medicine study, or the patient, for whatever reason, doesn't want to, we can also do a thyroid ultrasound with vascular assessment. And if the gland is incredibly vascular, that can also be indicative of a hyperthyroid state. So toxic nodules. These are more rare in children, but we still certainly see them. And these are diagnosed by having biochemical hyperthyroidism, or elevated thyroid hormone, or low TSH, a nodule, either on exam or on imaging. And if we do this uptake and scan, we have increased uptake. And here are some examples of different types of scans. We can see the normal thyroid, Graves' disease, where the whole gland lights up, a hot nodule where the most of the gland is actually has decreased uptake, but there's just one nodule that's lighting up. You can have a warm nodule, you can have multiple nodules, and so these are just some different examples of what we might see. The treatment for toxic nodule, you can use radioactive iodine ablation as opposed to evaluation. You can use a different type of radioactive iodine, the I-131, that will actually go just to that toxic nodule, because that's the only part of the thyroid gland that's active. The rest of it is sleeping, so it's protected. And that will cause, over time, destruction of those overactive thyroid cells and revert the person back to a euthyroid state. Up to 20% of the time that this does require retreatment with another dose. But 80% of the time, the people become euthyroid. We could do surgery to remove the half of the gland that has the toxic nodule, and this tends to be very curative. Less than 1% of these individuals require another form of treatment. But if they do have the entire thyroid gland removed, then of course they're hypothyroid and they would need to have thyroid hormone replacement. We can also use anti-thyroid medication in toxic nodules, but this isn't the preferred option because this requires someone to be committed to medication treatment for the foreseeable future. And if we can cure the nodule, that's preferable in most cases. Hashimotoxicosis is another hyperthyroid state that is a little bit unique because it's often the beginning stage of Hashimoto thyroiditis, or autoimmune hypothyroidism. This is seen in that chronic lymphocytic thyroiditis state. And the reason that we have this inflammation is that we have anti-thyroid T lymphocytes and antibodies, as opposed to stimulating antibodies. These are anti-thyroid, so they cause that destruction of the gland. And as we're destroying the thyroid gland, as the gland and the cells begin destroying, it releases thyroid hormone that's been stored into the circulation. And so we have this transient hyperthyroid state from released thyroid hormone, but not because the thyroid gland is overactive itself. Because we're only releasing what's stored, we're not producing more. This is typically a self-limited state. And we can diagnose this by biochemical hyperthyroidism, elevated thyroid hormones in the blood. And as opposed to having the positive TRAB or the positive TSI, like we would see in Graves' disease, these individuals much more commonly have positive TPO or thyroglobulin antibodies. If we were to do an uptake and scan, as opposed to having an increased uptake like we would see in Graves' disease, the uptake is actually low because, again, the gland isn't making thyroid hormone, it's just releasing what it has stored already. And we typically only need to use treatment for symptoms because this is a transient state. So if someone is having symptoms of hyperthyroidism, they're not sleeping well, they're having anxiety, they're having palpitations, beta blockers can be very helpful in this situation. You can use anti-thyroid medication in this situation if somebody is having a lot of symptoms and it's progressing for a very long time. That can result in the need for anti-thyroid medications, and they do work in this situation. So exogenous thyroid hormone, let's say that someone is being exposed to thyroid hormone either intentionally or unintentionally. And this can be because of a pharmacy error. The pharmacy is giving thyroid hormone either at the wrong dose or instead of something the patient should be receiving. let's say it's a child at home who isn't being supervised well by an adult and they're just taking thyroid hormone. Nutritional or health supplements. This is a big deal because a lot of people will take supplements that are touted as thyroid supplements or thyroid health supplements. And there was a study a few years back that actually looked at a variety of different thyroid health supplements, and they found that quite a few of them contained iodine, or thyroid hormone itself. So if someone is taking iodine in large doses, or they're taking a supplement and they don't know it has thyroid hormone in it, this could be an inadvertent cause of hyperthyroidism. There was an entity a few years ago called hamburger thyrotoxicosis, where in a meat packaging plant, thyroid tissue got into some of the meat that was being used to make hamburger, and people were ingesting the hamburger meat and having hyperthyroidism because of the inadvertent thyroid gland that was included into the meat. And we diagnosed this by the lack of a goiter on exam. Again, the person's thyroid is not doing anything, and so it's going to be sleeping. The thyroid hormone production is going to be suppressed. They have biochemical hyperthyroidism. We do their labs and they look hyperthyroid, but these people are going to have a low thyroglobulin level. Thyroglobulin is a protein that's produced by thyroid tissue. If someone is hyperthyroid because the thyroid gland is overactive, it's going to be making thyroid hormone and thyroglobulin. If someone has hyperthyroidism because of exogenous thyroid hormone, the thyroid hormone will be high because they're taking it, but because the thyroid gland is underactive, it's not making anything, that thyroglobulin level will be suppressed, and that's how you can kind of tell the difference between these two. They'll also have decreased nuclear medicine uptake. If they have that uptake in scan, again, the thyroid gland is not doing anything, it's going to have a low uptake. So if we're thinking about hyperthyroidism, things that I will consider, again, is a TSH, a total or free T4, and then that, total or free T4, and then the total T3 to look for that endogenous T3 predominant state. And then I will get antibodies looking for Graves' disease, the TSI and the TRAB, and I will also get the anti-TPO and anti-thyroglobulin antibodies to evaluate for Hashimoto's as well. So we're going to shift gears a little bit and talk about other causes of abnormal thyroid function testing. And biotin is a huge cause. Biotin is a hair, nail, and skin vitamin that's in a lot of different gummies and vitamins and supplements. And it is reportedly great for your hair and your nails and your skin. And it is also great for interfering with hormone tests. It's a B complex vitamin. And the reason that we even have to talk about that is because it's incredibly sticky. It covalently binds to a lot of different things: proteins, polypeptides, low molecular weight antigens, and hormones. It sticks to them, but it doesn't have much effect on their activity. And because of this, it's used a lot in lab assays as a ligand because it doesn't do anything, but it's very sticky. The problem is that because it is so sticky and it's used in so many different lab assays, including all of these that you see below, if a person is taking biotin and their serum is already saturated, and then their blood is drawn and put into a tube with an assay that also contains biotin, the biotin-ated assay isn't going to be able to bind to the hormones as effectively because the biotin the patient is taking has already done that. So we can have a lot of false results on our lab tests. Endocrine is about labs. We base our treatment decisions based on lab results. And so what do we do if somebody's taking biotin? Well, first we have to know, are you taking biotin? And they may say no. But then we also have to ask, are you taking hair, nail supplements, beauty vitamins, oral skincare products? All of these things can contain biotin, so it's important to ask about it. And then the lucky thing for us is that biotin is a water-soluble vitamin, and so it does flush out of the system after about 48 to 72 hours. And so I ask patients to just stop biotin at least 2 to 3 days before we're going to do the lab work, and then we should be able to trust the results. One caveat to this is that if somebody is taking more than 100 milligrams per day of biotin, it may take longer for it to clear the system just because of that increased saturation from a high dose. So other causes of abnormal thyroid function testing, we have to talk about illness and stress. Euthyroid 6 syndrome, also known as non-thyroidal illness syndrome, wreaks havoc on our thyroid function. We don't think that there's just one cause. There's a lot of different reasons for this. And when we're sick, we have changes in our deiodinase activity. We're either adding or removing iodine differently than we would be when we're well. We do have a decrease and then an increase in TSH secretion related to illness. There's changes in thyroid hormone binding during times of acute illness, and there's changes in thyroid hormone transport. So all of these things affect what our thyroid labs are going to look like without necessarily indicating that there's true chronic thyroid dysfunction. We also know there's some change in nuclear thyroid receptor activity in conjunction with illness. When we're thinking about deiodinases, this is a graphical representation of the metabolism and building and breakdown of thyroid hormone. T4 is in the upper left corner here. And if we're going to be converting it in the peripheral circulation, like we mentioned before, we have to have activity from our D2 deiodinase. In illness, we have decreased activity of that D2. And instead, we have increased activity of D3. This causes a shift from T3, which is the active form of thyroid hormone, to reverse T3, which is a very unhelpful thyroid hormone and is just part of that breakdown process. And so when we have more reverse T3 and less T3, we're going to have changes in our TSH secretion. So this is a trend for how the thyroid hormones typically evolve during critical illness. We can see that when we start out, everything's fine. But then we have that increase in reverse T3 from that shift in the deiodinases. Because we have more reverse T3, it's not as effective at causing that TSH suppression. And the body is seeing less active thyroid hormones, so the TSH begins to rise. As the TSH begins to rise, eventually it is going to stimulate the production of T4 and T3 as the person recovers from their illness. And so you're going to see this gradual recovery of our active thyroid hormones. And then as that happens, the TSH will go back to normal, the reverse T3 goes back to normal. But this is something that we have to trend over time. And this is why when someone's admitted to the hospital and they have thyroid hormone testing that's noted to be abnormal, oftentimes we won't repeat it right away. We'll give them a little bit of time to watch and see. So it's not recommended to treat with thyroid hormone because the benefits are none and the risks could be high, especially during critical illness. So right now, trending is the best thing to do. So let's say that someone was noted to have positive thyroid autoantibodies. Oh no, why did we check those? And they have normal thyroid function. So now what do we do? Well, we know that the prevalence of positive thyroid autoantibodies in the US population is about 40%, and this is in all comers. In kids specifically, we know that about 34.1% will have positive TPO and 5.1% will have positive thyroglobulin antibodies. Now, just because you have positive thyroid antibodies doesn't mean that you have a thyroid problem, but how do we know what to do next? When we look at the pediatric data specifically, they looked at 382 kids who either had positive thyroid antibodies or a mildly elevated TSH without autoantibodies. And they were, a typical pediatric age range, about 10 plus or minus a few years. And in the children with antibodies, 73% of them had a normal TSH at baseline. After 3 years, 79% still had a normal TSH. So they didn't go on to develop hypothyroidism. But 21% did. When they look at kids who had elevated TSH but negative antibodies, 39% reverted to normal TSH, 47% remained stable, and only 14% became hypothyroid. So when they looked at these two groups, the risk factors for developing hypothyroidism were in the positive antibody group, where if they also had an elevated TSH, if the TPO antibodies were the ones that were abnormal, and if they had another autoimmune diagnosis, specifically celiac disease. In the antibody negative group, there were no predictors. So the risk of developing hypothyroidism in positive antibodies seems to be a little bit higher, about 21% compared to 14% in those who have a mild elevation of TSH without antibodies. But we also know that treating people who have normal thyroid hormone testing hasn't really been shown to be helpful. So what we recommend is to monitor people who have positive antibodies, monitor their TSH and their free T4 and ask about symptoms, and only treat if they convert to hypothyroidism. So the thyroid weight connection. This is something we need to talk about. Where did this come from? So back 100 million years ago, once upon a time, we weren't able to monitor thyroid function. And so before the TSH assay became available, people would be admitted to the hospital with myxedema coma, significantly progressed hypothyroidism to the degree where they're not making any thyroid hormone at all. And thyroid hormone is really important for water excretion by the body. If you have no thyroid hormone, you're going to gain weight from water weight, from edema, but not from hypothyroidism. Recent studies in adults, after we've been able to monitor and catch hypothyroidism much earlier on, don't show any weight change. But this is a pediatric discussion. So what do we know about kids? Well, patients with hypothyroidism who are treated don't really have weight changes. And DEXA scans looking at pre and post treatment don't show any difference in body composition as far as fat mass before or after treatment. However, TSH and body weight, not hypothyroidism, there are some positive correlations between BMI and TSH. And people who have a progressive weight gain do tend to have a higher TSH. When we look at obese kids, between 10 to 23% of them have moderately elevated TSH levels, but normal thyroid hormone levels. This is a graph of TSH levels in children who have a diagnosis of obesity versus lean body weight. And we can see that those who have that obesity diagnosis do have higher TSH values. But I want to point out that both of the TSH values are still within the normal range. One hypothesis to explain this is that TSH actually might be a physiologic adaptive response to obesity. A decrease in a TSH of just 1 milliunit per ml can decrease your energy expenditure between 75 to 100 calories per day. So an increased TSH may actually increase that metabolic rate as a response to the obesity, and may actually be helpful to prevent further weight gain in people with obesity. When we look at kids with obesity, only 0.3% of these studied were found to have hypothyroidism. And when they looked at kids with hypothyroidism, a lot of them had a goiter, but weight gain was a very rare complaint. And when they looked at an additional group of kids with hypothyroidism, there was no significant change in weight with treatment. So should we treat? And small trials of levothyroxine in children who had obesity and a mild TSH elevation showed that the TSH came down. Thyroid hormone levels were normal before, they were normal after, the lipid profile didn't change, their BMI and their weight didn't change. And so should we treat? And I think it depends on what we mean by treatment. If we look at children with obesity and we treat with the lifestyle changes, the TSH actually decreases. There were 2 studies who found this. And so if you have a child who has a diagnosis of obesity and a mildly elevated TSH and everything else is normal, the thyroid hormones are normal, the antibodies are normal, treat, but treat with lifestyle modifications, not with levothyroxine. So what I want is for all of us in this virtual space to have good outcomes. We all want the warm chocolate chip cookies at the end of the day. And so what I would love is for us to partner together to get those cookies so we all get the right outcomes. And how we do this, right, is knowing what we know about thyroid physiology, knowing that these disorders are common in pediatrics. There's a variety of thyroid function testing, and knowing which ones to order is key in knowing what to do next. And There may be a relationship between TSH and body weight, but general thyroid function and body weight, not so much. And in order for all of us to get what we want, in order for all of us to get the cookies in the cookie jar, we're here to help. You all do such a beautiful job in primary care taking care of kids. If there's any endocrine questions or anything that you need, reach out and we are absolutely here to help. I think I went a little bit over time, but thank you so much for your attention and for being here and for taking such great care of our kids in Louisville and the surrounding areas.
Thanks, Dr. Folsom. We have time for one question. Would you recommend to check thyroid function in asymptomatic children with positive family histories for thyroid disease and first-degree relatives?
I don't recommend checking thyroid function if they're asymptomatic. If their growth is great, they're feeling well, they're otherwise healthy, I don't recommend routine screening unless I have a clinical suspicion that there is something going on.
All right. Thank you so much, Dr. Folsom.